We are going to talk today about interpreting arterial blood gases, and we have our method we use that we call ABGs in 3 easy steps, and it's actually 2 easy steps and 1 kind of hard step, but we'll get to that. I'm not going to do a lot of the theoretical background of arterial blood gases. I'm really just going to focus on interpretation. So just to go over again what normal values are, a normal pH is 7.35 to 7.45. And so if we look at that range of normal, we can sort of think of the perfect pH as being 7.40 because that's right exactly in the middle of 7.35 to 7.45. A normal PCO2 or normal carbon dioxide level is 35 to 45. And as we go through this method of interpreting ABGs, I want you to think about CO2 as actually being an acid, because then that will help you remember that if there's too much CO2, you'll end up in an acidotic state. And then, of course, the opposite is true. If there's not enough CO2, you can be in an alkalotic state. The next value is bicarb, which we abbreviate HCO3. And I want you to think of bicarb as being a base or an alkali. Those two terms are kind of interchangeable, base and alkali. Normal bicarb level is 22 to 26. Now, you might see different values in different books, but for our purposes, we say a normal bicarb here is 22 to 26. Now, again, you think of this as being a base or being an alkali. So if you have too much of this, you're alkalotic. The reverse is also true. If there's not enough of this, then you're acidotic. And then the other thing arterial blood gases tell us about is the state of oxygenation. And a normal PO2 level is 80 to 100. PO2 less than 80 means that you're hypoxic. Okay? So we have our normal values down. Now let's move to our 3-step method for interpreting ABGs. The first method is, or the first step in our method is to label the pH. And remember again, we said the perfect pH is 7.40. And so if we have a pH on our arterial blood gases that's less than 7.40, then we're going to say that that leans towards the acidotic side of the scale, because low pH means acidosis. If we have a pH that's greater than our perfect pH of 7.40, then we say it leans toward the alkalotic side of the scale. Okay, so that's our first step in interpreting our ABGs, and we're going to do a couple practice ABGs. The next step then is to determine what the cause of the primary acid-base imbalance is. And so once you've labeled your pH, then you have to look at the CO2 to see if it's a respiratory cause, and you look at the bicarb to see if it's a metabolic cause. And so if we had a pH that was, say, 7.35, we would say that that leans towards the acidotic side of the scale. Then we would go down and look at CO2 and bicarb to see if it was a metabolic acidosis or a respiratory acidosis. And again, thinking of CO2 as actually being an acid, if we had an acidotic pH and we came down and looked at our CO2 and our CO2 was high, we could say, oh, that's the cause of the acidosis. If we looked at the CO2 and it was normal, that can't cause acidosis. If we looked at the CO2 and it was too low, we could never say that that was the cause of the acidosis either, because a low CO2 would actually cause alkalosis. Okay? And in the same way, we would look at our bicarb. If we had a low pH, we would look at our bicarb. If our bicarb was too high, we could never say that that was the cause of the acidosis, because high bicarb causes alkalosis. If we had an acidotic pH, we looked at our bicarb and our bicarb was low, then we could say, oh, that's the cause of the acidosis. And then we could label it a metabolic acidosis. Okay? So that's the second easy step. Now, the third step is the step that's not really quite so easy. And this is that part about compensation with arterial blood gases. And that's the most difficult part of arterial blood gases. And so if that's still a little bit confusing to you at this point, that's fine. That's not surprising, even though you might have done ABG interpretation before. So let's look at how compensation works. After we label the pH and determine the primary cause of the acid-base imbalance, then we have to look at the CO2 and the bicarb together as a pair. Because the way acid-base imbalances work, whatever your primary abnormality is, if it's a respiratory cause, your body will try to compensate by changing things on the metabolic side. So if the primary disturbance is a disturbance of CO2, your body is going to change the bicarb to try and fix it. The reverse is also true. If the primary problem is metabolic, then your bicarb is out of whack, but your body will try to change your CO2 levels in order to try to balance that out. And what your body is always trying to do when it compensates is it's trying to get that pH back to within the normal range of 7.35 to 7.45. It's never going to overcompensate and push you to the other side of the scale. It's just going to try and get you back within the normal range. So once you've looked at, say, your acidotic pH, and then you looked at your CO2 and you see that your CO2 is high, then you have to look at your bicarb and say, now, as my body's retaining all this CO2, which is making me acidotic, is it also trying to retain bicarb to balance out all that acid by hanging on to more base? That's what compensation is. And so when you look at these two together, if the bicarb and the CO2 are both outside of the normal range, but moving in the same direction, then compensation is present. Because as your body's primary problem is hanging on to too much acid, your body will try to hang on to too much base to correct it. The opposite is also true. If your body is losing a lot of acid, like people who have prolonged vomiting and lose all the hydrochloric acid from their GI tract, as their body loses all that acid and they start to get a little bit too alkaline, what they'll do to try and bring the pH back down to within normal limits is they'll try to hang on to an acid, so they'll hang on to more CO2 to try and compensate. Okay? So once we've determined that compensation is present because we've looked at the CO2 and the bicarb, and they're both outside normal range and moving in the same direction, then the question is it fully compensated or only partially compensated? How well did this compensation work? If it's fully compensated, your pH will be normal. If it's only partially compensated, then your pH will still be abnormal. So partially compensated means CO2 and bicarb are both outside the normal range, both moving in the same direction, but the pH hasn't quite gotten back to normal yet. And so that is sort of how we determine if there's compensation on an arterial blood gas. And then the last step, as always, is to look at the PO2 and determine if your patient is hypoxic or not. So now we actually have a couple of ABGs here, and we are going to interpret them and apply our 3 easy steps. So let me just move this paper over. Okay, so we look at our first blood gas up here. We have a pH of 7.30, PCO2 is 31, bicarb is 18, and the PO2 is 81. So let's do our 3 easy steps. The first thing we do is we look at this pH, and remember we're going to say that 7.40 is our perfect pH. And if we look at 7.30, that's on the low side, which is the acidotic side. So we can say that we have here an acidotic pH. That's our first easy step. We labeled the pH as leaning towards the side of acidosis. The next step is to determine the cause. So to determine the cause, we need to figure out if it's a primarily respiratory problem or a primarily metabolic problem. So we have an acidotic pH. We look at our CO2 and we see that our CO2 is low. We have to ask ourselves, can a low CO2 cause acidosis? No, it can't, because CO2 is an acid. If CO2 was responsible for this acidosis, the CO2 would be high. This cannot possibly be the cause of the acidosis. So let's look at our bicarb. Our bicarb is low. Can a low bicarb cause acidosis? Yes, it can, because bicarb is a base or an alkali. And as you lose your base or you lose your alkali, you become acidotic. So we say, that's the cause of our problem. So this is the metabolic side, this is the respiratory side. So now we know we have a metabolic acidosis. The next question is compensation present? If compensation is present, then the other part is going to be outside the normal range and move in the same direction as the bicarb. What do we have? Low CO2. Is compensation present? Yes, it is. As our body is getting more and more and more acidotic, our body compensates by trying to get rid of extra acid. Blows off CO2 to try and get rid of acid. So yes, compensation is present. The next step in the compensation question is it fully compensated or partially compensated? Back to the pH again. Is our pH within normal range? 7.30? No, it's not. Normal range is 7.35 to 7.45. So yes, there's compensation present, but it only got the job done partially. So it's partial. And so how we would interpret this blood gas is we would say that it is a partially compensated metabolic acidosis. Is the PO2 normal? Yes, it is. So there's no hypoxia present. Okay? Partially compensated metabolic acidosis, no hypoxia. Good? Let's do the next one. Same process again. The first step is to label the pH. Perfect pH is 7.40. This is on the low side. Once again, we have an acidosis. So we look for the cause, the CO2. Is this high, low, or normal? Normal range 35 to 45. This is high. Can a high CO2 cause acidosis? You bet it can. CO2 is an acid. So we know already that we have a respiratory acidosis. Next question, is there compensation present? In order for compensation to be present, bicarb has to be outside the normal range. Is this outside the normal range? No, it's not. It's within the normal range. So is there compensation? No. No compensation present at all. So now we know what we have here is an uncompensated respiratory acidosis. Let's look at our PO2. Is that normal? Nope, too low. So the patient is hypoxic. So how we interpret this ABG, to put it all together, is to say that we have an uncompensated respiratory acidosis with hypoxia. All right, let's do the last one. Again, our 3 easy steps. First one, label the pH. Because this is higher than our perfect pH of 7.40, it's on the alkalotic side of the scale. So here we know we have an alkalosis. So let's find the cause. We go to our PCO2. PCO2 is high, normal range 35 to 45. This is high. Can a high CO2 cause alkalosis? No, because CO2 is an acid. So that's not the cause. Let's look at our bicarb. We look at our bicarb, normal range is 22 to 26. That's high. Can that cause alkalosis? Yeah, you bet it can, because bicarb is a base or an alkali. So we know here that we have a metabolic alkalosis. Is there compensation present? Let's go back to the CO2. It's high. Is there compensation present? Yeah, it is. These are both outside the normal range, and they're both moving in the same direction. So we have compensation present. So how we would interpret this is we would call this compensated metabolic alkalosis. Is it fully compensated or partially compensated? Back to the pH. Is that within normal range? No, it's not within normal range. So even though our body's trying to compensate, it hasn't quite gotten the job done yet. So we're going to call this partially compensated metabolic alkalosis. How's our PO2? 80 to 100, our PO2 is fine. No hypoxia, okay? So that is a partially compensated metabolic alkalosis, no hypoxia present. So that's how we interpret ABGs in 3 easy steps. There are some practice ABGs posted on your WebCT course website. If you would like to try those ABGs and post your answers on the course website, your instructors will be happy to give you feedback about that. And please post any other questions you have on the WebCT site. Thanks.